So going back a little bit in time, this is a bit of the trajectory that we have in relation to the opiate epidemic. So the first phase, or the first wave, as they call it, was what we now know as kind of the pharmaceutical boom, where there was this overprescribing of pain medication, pain management, and that started the initial rise in opiate addiction, opiate use disorder, through things such as Percocet, through things such as oxycodone, and having the prescriptive opiates be kind of that first initial wave as far as the addiction crisis began. The second wave was in lieu, obviously, of the increase of that prescription use and abuse. We saw a significant rise in overdose deaths. And I think that's also what began to really show individuals that, okay, this is not only a highly addictive substance, but this is also a very deadly substance. And so, with the rise of the opiate prescriptions, and then in turn with the rise of heroin, the rise of overdose deaths, again, seeing how dangerous this can really be. And then the third wave is the rise in synthetics. Now, as you can see, looking at kind of that third wave, how things spike so significantly. It went from, not that any of these are good numbers per se, but going from that baseline and shooting up to that catastrophic, frame really shows again why they put the staple of opioid epidemic on this. And we see when we look on kind of the right side of the graph, how prevalent synthetics are now part of this epidemic. It's not just prescriptions, it's not just heroin, it is synthetics, and it is a mix, and it is a combination. And because the complexity of that, also from the clinical sense, we need to be aware that opioid use disorders does not just equal heroin use. It does not just equal medication use or abuse, that there are a lot of kind of complex factors that go into it just merely based on kind of the product itself. So that's a bit historically of kind of where we are currently at this time frame. Again, currently we are seeing the rise of synthetics, and from that we see additional substances that are coming into play. It's very important to note fentanyl. Fentanyl, as we saw previously, has definitely increased the risk, increased the potential of overdosing in individuals. And if you see from the graph right there, that on the tip of that pencil is a lethal dosage of fentanyl. That's all that it takes. And it is 50 to 100 times more potent than heroin, which again is hard to comprehend what that is, but keep in mind, because it's less product and because it's a stronger product, it becomes more kind of, for drug dealers and for users, it becomes more kind of an affordable kind of cutting. Okay, so I don't have to include as much heroin within the product, and now I can cut it with fentanyl, and now that's going to be a stronger product, and now more people are going to want that. The difficult part is, keep in mind, yes, it's increasing the overdoses, but when we see patterns of overdose based on certain kind of products, individuals actually begin to seek that product out. Why? Because they know it is then more potent. And that, again, is part of the devastation that comes with this. Another kind of new factor to be very well aware of is xylazine. Xylazine is not an opiate, but what we are seeing now in opiate product, heroin, and even in combination with fentanyl, is the addition of xylazine. So just so everyone knows, xylazine is a veterinary sedative, usually used for horses. So it was not made for human consumption. It was not made for the human body. And it is something to which is used in veterinary offices. It is often mixed with heroin, cocaine, counterfeit medication pills, and the combination of the fentanyl, the heroin, or the other opiate in line with the xylazine can be very deadly. So you may ask, why xylazine? Why a horse tranquilizer? What is that kind of doing? I had to look this up myself. So it prolongs the high. So the fentanyl, albeit very strong, has a very short duration of action, meaning it's a super high, but it's a super quick crash. And so the sedative prolongs the euphoric effects and making the high last longer. So it's going to keep you up there and it's going to keep it at that height for a longer state. And like I said before, it's also cost effective. Xylazine is cheap, it's accessible. They use it to then, in turn, as dealers have done with fentanyl, also cut that into fentanyl, cut that into heroin to increase profits while maintaining or enhancing the drug's potency. So again, if you are a dealer and now you have this more affordable product that now is going to enhance your already synthetic product, not only is that more effective, but you are going to be sought out more because you have that increased potency of that type of drug. And so again, that becomes much more, wanted as far as individuals seeking that high. But keep in mind, it intensifies sedation, which again is where it gets dangerous. Opioids, as we know, kind of are uppers, and this is a sedative. So you have kind of this duality within the body that can make it, again, more dangerous and more at risk for overdose. Now, keep in mind, with us being in kind of this northern area, the pattern of things such as fentanyl and xylazine, it comes through the Northeast. So we tend to be kind of the hub and the access point of these materials, of fentanyl, of heroin, of xylazine, and kind of the products kind of are cultivated through here, which is why, like for us, myself, I'm in the Bergen County area. We're right across from New York City and we're right on the water. So we see in our close kind of city of Patterson, we have a very pure product coming in. And we have dealers are then cutting that product, distributing that product. And, for us in Bergen County, we are the road directly then to New York City. And that becomes kind of an epicenter. So usually with this drug distribution, we see it come in through the Northeast. We see kind of it then spread to the South and then spread out west. So with xylazine, it kind of began, I think folks heard like within the Philadelphia area. So that's typically how we see with these drug trends. And so it's good to keep in mind that for us on the northeastern side of the United States, a lot of times we're going to be the first to see these products come out, and we're going to be the first to start to work with individuals to whom may be struggling with these products. So it's always good to be kind of on the cutting edge of what's going on, and again, how we can support those in our community. When we are looking at kind of what can be at risk for individuals, keep in mind, these are what we call pressed pills. So on the left side, you are seeing the actual medication, and on the right side, you are seeing a manufactured medication. So what is very dangerous about this is that you don't necessarily know what is in that manufactured medication. And as we spoke of before, you can have things such as fentanyl, such as xylazine, such as cocaine in, kind of cut into these medications, because the thing is the medications themselves, in their pure self, like oxycodone, Xanax, they're expensive. They're quite expensive, and they're expensive on the street. And that's why a lot of times individuals transition to heroin use because, an oxycodone that may cost $40 for me to have one pill, I can buy a bag of heroin for $5. So the hard part is, again, it can be a transitionary into higher levels of use, but even the medication themselves may not be safe. I had worked with an adolescent one time. She had come in for treatment because she had been hospitalized. And when they had tested her, she had tested positive for fentanyl. And everyone was so perplexed. Gosh, she's a 15-year-old girl. How is she, how and why is she using, this very synthetic, very dangerous opioid? A friend had given her a medication. Her friend had given her a painkiller. Now this was an individual who did not have any history of recreational substance use, did not have any history of abuse of any product. And in taking that medication, unbeknownst to her, she nearly overdosed on that. And that is what is so important to be aware of, especially in working with clients and educating them about what they put into their body. Because this is very important psychoeducation for ourselves for our communities, but again, also for the people that we serve. So naloxone, also known as Narcan, we know that this has been a significant literal lifesaver in the combating of the opioid addiction, combating of overdose deaths. And we know and we have seen it make a really, really big difference. What is so wonderful about Narcan is that it can be used by a layperson. As you see in the image, this is a nasal spray. And what is great about this as well is that it does not harm an individual to whom does not need it. Meaning that if you were to find someone passed out on the street and you gave this to them, if they are not under an opioid overdose, it is not going to harm their body or put themselves in any distress. And so honestly, what we see now in emergency first response is if they come across someone to whom is unresponsive, they will automatically give Narcan. Just as a first kind of, okay, let's see if this is in relation to an overdose, because we also know the quicker we can give that, the quicker we can hopefully save the life of that individual person. What's nice too is we see a lot of this now accessible in the community. We see a lot of this at pharmacies. We see a lot of programs that are really trying to get Narcan out. Narcan out available to families, Narcan out available to people in the community. And as a clinician, it is very important if you're working with someone with opioid use disorder to have conversations about Narcan. Do you have it? Are you familiar with it? Is it in your household? Do other individuals know how to use it? Just because this can be such a life-saving tool to have, and it's so important to just know, again, the risk for opiate use, again, it just has to be one potential pill. It doesn't have to be kind of an extreme thing to be an overdose. Now, what I will say, the difficult part with Narcan and xylazine is because xylazine is not an opiate, it does not work on xylazine. And this is why the incorporation of xylazine is so dangerous right now. Because xylazine is a sedative, it is putting the body in respiratory depression. And you can give someone Narcan, and that's going to help on the opioid receptors in the brain. It's not going to do anything for the xylazine. And so if someone is in enough respiratory distress, they may not then in turn come back from that overdose. And so it's really important to know that as much as this has been life-saving and wonderful, introduction of additional, kind of medications such as that can make it much more difficult and much less safe. So why does this matter? So as clinicians, it is important to know that opioid use disorder does not live in a particular community with a particular person with a particular demographic. It lives everywhere. It is everywhere. It is addiction is the thing that cuts through socioeconomic status. It cuts through gender. It cuts through all of these demographics. Now, obviously, we do see populations to which are, more at risk, more vulnerable, more marginalized. Yes. But again, this is something that can impact anyone, anywhere. Now, we have also seen that, again, opioid addiction can start legitimately, meaning that someone could get a prescription based on chronic pain for an opiate medication, and then all of a sudden it becomes a physical addiction. Keep in mind, it does not take a lot to become physically addicted to the substance. And that is also what is so difficult about opioids, is it is very physically addicting. It is beyond just, I feel like using it or not. It really creates that attachment within the body. And it is very, again, as clinicians, important to ask these questions. Like, even if someone is coming in for anxiety, depression, this is why we always ask about substance use, recreational use. And this is going to help us as we see tailor our treatment plans, support equitable access, again, knowing kind of the vulnerability that can come from underserved populations, strengthening our resources in the community. Again, it's good to know who does what. Okay, who can provide detox care? Who can, prescribe Suboxone? What residential places are out there? It is important to build these kind of referrals and care coordination within the community, because again, it is inevitable that you will come in contact with someone who has opioid use disorder. And so we want to be able to know how to best help, how to best serve them. We also want to be able to promote ethical, stigma-free care. Listen, we're all human. We may have our own thoughts and feelings on substance use. We may have our own thoughts and feelings on addiction. And we might have biases. We might have prejudice. We want to keep that in check. And the more we can learn about what addiction really is and how impactful it truly is, the more we can empathize. And that, again, as clinicians, is what we're always trying to do. We're always trying to empathize with the individuals to whom we serve and see beyond the symptomology, to see the human and to help the human within the situation. And so for us, that's why trying to stay on top of these things is so important. So we can kind of use that fact to combat, again, our own prejudice, our own bias in the situation. And it also just makes us feel more confident and trusting. As clinicians, I've worked with a lot of clinicians, and we've all been there. We've all had that where kind of like, I don't feel comfortable working with that population. There's a lot of, again, preconceived notions in working with substance use clients. Well, they're not going to engage in treatment, and they're always going to relapse, and they're whiny, and they're this and they're that. There's a lot of these conceived notions within our own field. But again, through knowledge and repetition and engagement, we can see very quickly, like, they're just people. They're just people. And this is their struggle. And as we would help anyone else with any other type of struggle, again, the more we learn about what they're struggling with, the more then we can provide evidence, value-based care and feel more confident about our skill set in those spaces. And we don't have to be afraid then of working with someone who has opiate use disorder. So some of the modalities we're going to go over, these are kind of some of the best practices, but keep in mind our field continues to change and evolve thanks to research, thanks to different studies, thanks to different technology, thanks to different scientific evidence and discovery. So we're going to go over a couple of those and just kind of discuss how they kind of work best within this context. So harm reduction. There's a lot of controversy surrounding this. People have their own belief systems in regards to this. Some people feel it enables those to whom are using substances, and some feel that it is, going to help them begin to make the change. Now, I will give my own 2 cents. It is my own 2 cents. But what evidence shows us is that when we engage and provide harm reductive modalities, it does reduce overdose deaths. It does prevent more of the transmissible diseases that can come from substance use. It promotes dignity and empowerment, and it also helps in treatment engagement, because we know when someone meets us where we're at, we're a lot more likely to then kind of meet that person in the middle too. If we feel as though it's an all or nothing situation, that might be difficult for us to kind of buy into. So some of the harm reduction modalities that are out there, it could be housing, Narcan we spoke of, safer drug use practices, needle exchange programs, different pharmacy access, medication-assisted treatment, the supervised community service where individuals can come in to use and to receive clean needles and to receive, medical support, therapeutic support. And so again, as I said, we've got even things I'll bring up to the fentanyl test strips, and they're even trying to come out with xylazine testing now, so users can test their product. And again, people may say, well, isn't that encouraging them to use? They're going to use it regardless. This kind of comes down to even the discussion of contraceptives. These things will happen. Individuals are going to use, but when they are alive, there is hope and there is chance for change. If they pass, that's not. And so again, for me, from a harm reductive standpoint, from a motivational interviewing standpoint, I would always rather have the opportunity to put that person back in a chair and work to engage in change than to have them lose their life in this situation. Medication-assisted treatment. So again, some of you may be familiar with these. This is FDA approved medication that works in tandem with counseling and behavioral therapies. It is the gold standard for opiate use disorder treatment just because these medication assisted treatments truly help from the physical dependency side of things to really help with things like cravings, to even reduce the euphoric effects of the medication and to help the body physically become unaddicted from the medication. And that's why it works so well in tandem with counseling services. And that is really kind of the two-part gold standard. It improves retention in treatment and reduces kind of, again, ongoing continued illicit use. We see products like methadone, that is a liquid. And as you can kind of see, again, I won't go through each single part of it, but each of these kind of serves its own, how it impacts the opioid receptors, how it, again, either reduces cravings or the euphoric effect. So that way, if someone should use illicit, opioids, it's not going to give the same high. You can see through the different types, kind of the utilization of it. The methadone is a daily use. The buprenorphine, which is also known as Suboxone, or the naltrexone, which can also be known as Vivitrol. You see how these also work as far as, daily use or once a month, every 6 months. So again, thankfully, there's enough where it is catered to that individual person and what might work best for their needs. One thing that I will just say that's always an interesting piece of information is individuals have to be very careful when starting medication-assisted treatment. When I say that, there's usually a 7 to 10 day period where they have to completely stop using opioids. This is where an individual would be going to a detox. This is where they would be safely, medically monitored in order to get those out of the system. Reason being is if someone were to still have, opioids in their system and they are now using Suboxone or receiving an injection of Vivitrol, it is going to incur what we call precipitative withdrawal. And that means immediately the person's body is going to go in withdrawal just because the medication is taking, away kind of the opioid receptor and leaving that kind of now without anything, which again is the purpose of it. But that individual may be now very much going into a withdrawal state that can be dangerous and that can be very, very uncomfortable. So I will say again, when these medication-assisted treatments are used, they are working with the individual to just make sure that they are at a time where it is out of their system and it will not be harmful for them to take the medication. So cognitive behavioral therapy, we're all pretty familiar with this, but within the context of substance use and co-occurring, this can be extremely helpful as far as recognizing and modifying negative thought patterns, including substance use and how that is kind of the behavioral reaction, teaching coping skills, managing cravings, stress, triggers, problem solving, emotional regulation strategies, and CBT reduces relapse rates and improves long-term recovery outcomes. So again, what is nice is CBT really works in tandem with the thought, emotion, behavior, and really for that individual understanding how substances fit into that equation. And what is nice is when there is more awareness, then there's more opportunity for change, to change some of those thought patterns. Motivational interviewing is another gold standard when it comes to substance use treatment. This is one that a lot of people hear about, especially in substance use. Reason being is a lot of individuals can come into substance use a lot of times based on external referrals. DCP&P, Division of Child Protection Services wants them to come in. They're mandated through their job. They're mandated through the legal system. Their family wants them to come in. So a lot of times we're seeing people who might be very pre-contemplative may not be at a point of acknowledging that they have anything that they want to work on. And so MI really helps to meet that person where they're at. It's client-centered. It's looking to enhance the motivation for change. It's looking to resolve that ambivalence and to build kind of that self-efficacy and self interest in recovery for themselves. Lots of open-ended questions, very reflective listening, affirming, just because, again, we're trying to meet that person where they're at, build that rapport, and really encourage them to make change at a pace that works for them. It increases treatment retention and engagement. Again, if people feel heard, if people feel seen, if people feel that you're going to meet them where they're at, they're more likely to then continue to engage in the treatment process. So one thing I wanted to bring up that is my own kind of side, looking at it, is the utilization of exposure in opioid use and even just substance use treatment in general. So ERP is the exposure response prevention. A lot of times the gold standard for ERP is in relation to OCD tendencies and behaviors. It's a behavioral intervention that can be adapted to addiction work. It is utilizing exposures in a controlled environment that can reduce the avoidant or reactive behaviors to prevent those impulsive and using responses. It helps doing that through distress tolerance. And what I think is very important to note with substance use is a lot of times the reason substance use has become so prevalent is because the distress tolerance has completely diminished. Because that individual person, anytime they reach that vulnerability, they're now going to go and, the impulsive and the reactive response is then the use of the substances. So the idea behind exposure work in substance use is to, instead of necessarily, we've heard like avoid people, places, things, avoid triggers, not saying that we want anyone to necessarily go walk into a liquor store after they come out of treatment, but it's more so the understanding that they will be exposed. They're not going to be able to live a life where they don't run into these factors, where they don't see someone drinking at a bar or they don't, have potential encounters and triggers. And a lot of times, because their distress tolerance is still not fully built, that's why we see the potential of relapse be so much. And so again, the idea of this is to actually help them to build that habituation to vulnerability, to pain, to stress. So that way they have it within them to hold space for that difficulty, for that feeling where they don't feel they have to escape, because that's where we also see a lot of transitioning of addictive behaviors. You might have someone that is stopping their substance use, but now they're gambling, or now they're engaging in, unhealthy eating behaviors. They're engaging in unhealthy sexual behaviors because the distress is still there and there is still this desire to escape. And so again, this is kind of a different way of looking at it and a different way of them potentially working and treating individuals. So I always say in our groups, we create brave spaces, not safe spaces. Reason being is, again, in treatment, whether it's individual, whether it's in group, part of the idea is to feel discomfort. Part of the inevitable thing that will happen to all individuals, and especially in care with us, is discomfort. And that doesn't have to be bad. We don't have to run from that. We don't have to hide or fix that. Any of those moments can be a great teaching moment and a great exposure moment to help that individual to be present in their distress and to go through the process of feeling the emotion, but still being there with themselves. So that's kind of just a different way to kind of look at substance use treatment. What is nice is one silver lining of the pandemic was being able to have more telehealth integration, especially when it comes to MAT provisions and work with prescribers, access to clinicians. Peer support has been a wonderful introduction as well. So we have in New Jersey recovery peer specialists, and these are individuals with lived experience, that are now in recovery themselves, that can really give that, kind of real life support to individuals who are seeking their own recovery, which can additionally help with treatment retention and really building that therapeutic connection. Integrated care, very important in substance use, especially opioid use disorder, where we're looking to work with outside prescribers, other holistic practices of recovery, and coordinating with the team and the family that is kind of surrounding that individual person. So, as we spoke of before, it might be a little tough in engaging individuals in substance use treatment, just as far as pre-contemplation. What we're really looking to do is to set realistic expectations. And again, this is where motivational interviewing can come into play. Okay, you don't have an addiction? Okay. What brought you into treatment? Oh, okay, your mother told you to come. Okay, why do you think she would want you to come into treatment? What has she seen? Again, trying to be curious, trying to be inquisitive, trying to understand from their perspective what factors are playing in. Open-ended questions, again, very MI based, transparent information about treatment. Okay, here's the options that we can do as far as really making sure all of your needs are being met while you're with us in care. Normalizing setbacks. So there is a difference between a lapse and a relapse. And this is just part of the treatment journey for individuals, especially with opiate use disorder, just because it is such a strong, pervasive addiction that it is not something that just kind of goes away on its own. It is a journey. And so, really normalizing whatever that individual journey looks like for that person, but also normalizing it for ourselves without judgment. We don't want to then be the clinician that is then frustrated. Oh, he went out and he used again. Why does he keep doing this? Well, let's ask. Let's be inquisitive, let's be empathetic, let's be, understanding, and let's really understand what's happening to that person. Revisit expectations. Again, this is where we might have to do kind of treatment agreements, behavioral contracts, if we see continued use, if we see non-compliance, again, but really coming back to the expectation and how do we meet these goals? What are the perceived barriers? How do we work together to, push forward through those barriers? Can we use outside people to bring in to help us with that? And let's just keep making sure we're on track. Client-centered communication. So again, a lot of I statements, I noticed, and being very objective, like, I saw this, I heard this, you said that, like, because we do not want to be judgmental. We do not want to be assuming. We do not want to be presumptuous. So this is where, again, the MI strategies of reflective statements, really trying to make sure we truly understand from that individual's perspective, clarifying questions. Again, if you don't get it, ask. Especially a lot of times, substance use individuals may come in and say certain language and certain words and certain terminology that you're unfamiliar with. Please ask. Don't make the assumption. I've had to Google things after the fact, but it is good to understand what that individual is speaking of. Pay attention to the verbal, nonverbal cues, validation, collaboration. I like this statement. What would it take for this to feel manageable for you? So really trying to, when and where you can, create autonomy that that individual can be a participant actively in their own treatment. Like even with treatment agreements, you're trying to put the ball back in their court and say, okay, this is what I saw. I've seen that your attendance has been lacking. Okay, what are we going to do about it? And then what will be just the natural consequence if this isn't followed through? So giving them the ability to then, okay, I can enact the change. I know what is expected. Again, anytime we can grant autonomy, that's going to help the person feel more a part of their own care and not just having their care kind of dictated to them for them. So just on a little legal side note, when we are speaking of substance use, we have what is known as 42 CFR Part 2. Most of you all, hopefully, are familiar with HIPAA and HIPAA compliancy and how that integrates within kind of the mental health world and mental health work that we do. Keep in mind that with substance use folks, there is an additional protection beyond HIPAA, and that is called 42 CFR 2. Reason being is, as we know, substance use can be very stigmatizing to a person, whether it's through an employer or through family or through friends, through even primary health care. If those records are exposed, that could be potentially very detrimental to the individual who is seeking care or who is struggling. And so this is designed to protect that stigma and protect in additional ways that privacy. So as you can see, it's federal regulation that protects the confidentiality of substance use treatment records. It limits disclosure of patient information from federally assisted substance use programs without written consent. So this is why when folks come in to see us and work with us, again, we're always getting release of information. We're always making sure the individual understands that, just because, again, we do not want to breach confidentiality, especially when it comes to our substance use folks. And this is why, again, release of information is important, because we see with our substance use folks, it's so important to make sure we are working collaboratively, but we need to make sure we're doing that in a legal way that is, again, going to protect that person. Monitoring outcomes, again, a lot of it is through lab testing, through standardized tools, ongoing case review, with supervisors or in clinical rounds, really trying to see kind of where the person is at, if the level of care that they're at is still kind of best served for them, to minimize some of the risk that can go on throughout the treatment time. We have relapse prevention plans. Those can very kind of just clearly identify, similar to as like a safety contract. It's identifying, okay, what are risk factors? What are protective factors? Who are you going to call? Who are you going to reach out to? A relapse prevention plan can be very powerful for an individual who has that vulnerable moment, but now has the idea of what they're going to do to keep themselves safe in that situation. Medication-assisted treatment, again, gold standard, reducing those cravings and helping that individual, again, not have so much of that physical dependency. Early identification of diversion or relapse behaviors. So again, this is where really teaching individuals about these trigger points. What are external triggers? Meaning like, okay, going to this certain place, being in this certain area, hearing this certain thing. Internal triggers, boredom, hunger, sadness. So really trying to educate and raise that awareness for that person to really understand where the discomfort comes from, where we can work again to build that distress tolerance, but understanding the risk that that can pose to that person. And support systems, oh gosh, outside support groups such as AA, NA, Smart Recovery, peer support groups. There's thankfully a support group for everything now. Another good thing that happened with the pandemic is a lot of these support groups went virtual. So even if this individual can't get to somewhere in person, there is a plethora of online resources that individuals can reach out to and get that community support, and even trying to integrate family or loved ones into the process, just because, again, it's not an individual journey. That person is one part of a whole, and any way that we can integrate that community into treatment is going to help their outcome potential as far as success goes. So treatment plans, yay. So treatment plans, we just want to make sure they are tailored to the individual person, that they are addressing the substance use, but that they are equally addressing the mental health. Again, we do not have one typically without the other. So we have to understand how these interact, how they kind of feed into each other, and separately, how they're individually going to be addressed. Also making sure we are pulling in prescribers, we're pulling in care managers, we're pulling in recovery coaches, family, anyone else, again, that is a part of this individual's treatment, and really trying to make it a collaborative effort, just so that way, again, they have a higher potential of success and have more support. Another thing is just making sure, as we say, an individualized plan, that it is also catered and understanding client preferences. So what things are they able to do? How does culture, how does language, how does learning style also impact that? Just so that way we're not setting up unrealistic expectations for that person. So these are just examples of some smart kind of goals in relation to substance use. Someone who says, I don't want to rely on substances to cope anymore. Client will maintain MAT compliance 100% weekly for the next 90 days, is verified by pharmacy and prescriber notes. Client will submit to UDS 100% negative results for opioids over the next 12 weeks. These are just ways, again, that we can quantify what we are looking for within the substance use component, and some of the interventions in turn that we can provide. like with weekly individual therapy, like with psychoeducation, working with a prescriber, working with a PCP, working in IOP, whatever that might be, but making sure that also that is integrated. Um, Looking, okay, what is their kind of outside support going to look like? Implementing potentially the use of community support programs and the attendance that they are willing to commit within that. Um, Making sure they're doing, again, what is good for themselves with jobs, with medical care, with family. Again, if these are impacting factors that have either gone neglected in the past or have been part of the trigger point for that individual in substance use, we want to make sure that we can put that on there too. Keep in mind, treatment plans are flexible and they're fluid, meaning that you might start kind of a broadband, kind of treatment plan in lieu of that substance use. And that may shift over time. You might start with kind of risk management of like, okay, first off, we want to make sure you're safe. First off, we want to make sure we are working to prevent relapse. And when we are working past that, okay, now let's delve a little more into family. Okay, now maybe we add that and maybe we bring a family member in. So keep in mind, you may have more of kind of a starch plan to begin with, one that is obviously addressed and focused upon safety, but then that might expand over time. Again, depending on the needs of that individual and depending on what makes most sense as far as where the treatment is going. So at this time, we're going to do a little bit of a small case study and discussion. So what I would like everyone to do is to take the plethora of information to which I have thrown at you, and to be able to use that in lieu of looking at the treatment we would potentially provide to this incoming person. So the client is a 41-year-old male with opioid use disorder, generalized anxiety disorder, and recent job loss, have a history of medication assisted treatment noncompliance, and strained family support. So that's just a little blurb of the individual who's coming in. And some of the discussion point prompts will be what services should be prioritized in the treatment plan? How would you build collaboration across providers? What community resources can support recovery? And how would you support engagement and reduce relapse risk? So, if I might receive support from someone in breaking out those small groups, I can unshare for a second so that way we can do that. Okay.
Awesome, Katie. I'm going to break us out into about four breakout rooms so we could go over and through the case study, okay?
Perfect.
Awesome. Thank you all for hopping back into the main room. I'm still waiting on a few attendees who are still working through some breakout room discussions. And then we're up at 10, so we have about half of our participants back.
Did anyone who has returned want to volunteer to share a little bit of what you had come up with within the context of your group discussion?
I just have a quick question, Katie. Do we have any in-person subgroups or is it all virtual?
I think, and Dr. Erica, you let me know. I know for us in Paramus and Mawa, right now we are virtual. We have been trying to in Mawa get in person. It's just been a little tough getting that full kind of attendee list to kind of get it up off the ground. Was there any other locations that did the in-person?
Greensburg and PA does
Okay.
in-person groups.
Okay, wonderful. And again, a goal that we have is to do hybrid. That would be the goal for both our mental health IOP as well as the substance use one too.
Thank you.
Of course. Anyone else want to share in regards to some of what they went over in their group discussion? Am I going to pick on someone?
I'll speak up. I'm in New Hampshire and we only do veterans and first responders is we don't do Gen Pop except for, spouses and family members. Um, and then Sheila and I were in the breakout room, and she also works only with veterans and first responders. So, what we really spoke of is that well, we didn't have the description in front of us, but what we really focused on was the history of MAT noncompliance and strained family support. So, because of the history of MAT noncompliance, we talked about putting the individual into an IOP program, which has, higher frequency, more engagement around substance use disorder. And so starting there, doing, figuring out why there's a history of MAT noncompliance. Is it side effects from the medications or whatnot? Unclear what the shaky, strained family support is. Like, is that wife and children? Is that extended family? In other words, how robust is the support system? Like, although the wife might not be supportive, does he have parents, for example? So unclear what community supports there would be. And so that's about as far as we got. But the reducing relapse risk would be the IOP, like increased clinical engagement with further investigation as to the support system and why MAT noncompliance, whether it's a medical response or is it a reluctance to change.
That's perfect. And I think that highlights really what we're trying to identify is that first and foremost, we want to be attentive to risk. We know with opiate use disorder, there's a higher potential of overdose. And so really attending to the MAT, really attending to relapse prevention, engaging in a higher level of care where there's more oversight. Of course, that's the best place to kind of start. I did want to, as we have a final minute left, if there were any questions that anyone had that I can answer.
Awesome. Thank you, Katie. I actually just had one question that came in through a chat separately. And this clinician had stated that I sometimes struggle with how to hold clients accountable when they're
Mm.
following their treatment plan, especially without it feeling confrontational. Can you talk about ways to approach that more effectively?
Sure, this is where MI really comes in handy, trying to understand from the perspective why the client finds it that they are unable to meet the expectations, the responsibilities of their plan, to understand if there are certain things that the program or client can do to overcome those barriers. But inevitably, we are also natural consequence. We want to make sure we're not part of the problem, we're part of the solution. So we have to be careful not to kind of engage in that enabling behavior as other people in their lives may have done. So that's where treatment kind of contracts come into play. And that's where us saying, like, listen, I hear you. But as we discussed before, this was the expectation. You were unable to comply with it. And because of that, we need to refer to additional treatment or we need to refer to a higher level of care. The hard part is sitting with our own discomfort because it's never a comfortable conversation, especially when we are met with frustration, anger, sadness. But it's us being able to hold space for what is most safe. With opiate use disorder, it is a little easier just because again, there is such risk that you always go back to that discussion. To make sure you are safe, we need to do X, Y, and Z. To make sure you are well and okay and healthy and alive, we need to do X, Y, and Z. So always going back to that primary medical risk is always something you can do, but also acknowledging that it's not going to feel good. It's not going to feel good to be an authority in that state. But we want to remember, again, what is the productive thing to allow for, as opposed to what we might want to do for ourselves.
Awesome. Thank you, Katie.
Thank you. And we are at 101. So thank you everyone so much for hanging in there an extra minute.
Thank you, Katie. Thank you, everyone. Enjoy the rest of your afternoons.
Thank you, everyone.